Halawa. Bismillahirrahmanirrahim. I'm delighted to be with you. You know why? Because it's home. As simple as that. You know this city? This is the first time for me to be here. Actually, I'm enjoying it. I'm enjoying the friendship. I'm enjoying the environment. I'm enjoying work. I'm a transplant surgeon with special interest in endocrine, especially parathyroid disease. Surgery is much easier than metabolic bone disease. It's easy to understand, but it's not easy to do. I'm always impressed with the history, because you need to know what the people did before you and how they thought about it. Sir Richard Boyle, in 1849, he's a British surgeon, fellow, Royal College of Surgeons. He's the first one who described the parathyroid gland. Do you know where about? In Indian rhinoceros. Khartit. Pyramid of Khartit. As similar to that. In 1879, Anton Walker described tetany in relation to total thyroidectomy. So, total thyroidectomy has something to do with the calcium, but he couldn't understand why or what happened. Then a Swedish medical student named Ivar Sandstål is the first one who described the parathyroid gland anatomically, microscopically, and microscopically. In 1909, calcium measurement was possible and became correlated, associated with parathyroid disease. In 1925, the first successful parathyroidectomy in a 38 years old patient with ostitis fibrosa cystica. A question. Do you think ostitis fibrosa cystica is a common presentation?
According to the community. According to the community.
Look, the disease phenotype has moved a lot, has changed a lot. In the past, 50% of the presentation was ostitis fibrosa cystica. These days, 5 to 10%. All right? This is the Indian rhinoceros, and this is Sir Richard Boyle. And this is the neck. This is a pointer here. This is a pointer. So this is the thyroid gland of the Indian rhinoceros, and he discovered a small gland next to it. He called it parathyroid gland. A gland which is next to the thyroid. This is Ivar Sandstål. You may think that this slide is quite silly because it's talking about anatomy, reverting back to the basics. Actually, this is for myself. I have to remind myself all the time with the basics, anatomy and physiology. Otherwise, I will get lost. In surgery, if you cut corners, if you make shortcut, you will lose the field. You will lose the patient. The standard anatomy tells us, in the standard textbook, there are 4 glands. Is it right?
No.
It's 84%, means it's not 100%. Could be 3 and 3%. We have seen it a lot. Could be 5 or more, especially in renal failure patients. So, finding 4 is not the answer. It could be 5. Finding 3 could be the answer. But you have to rule out extra gland, 4th gland, or even 5th gland. So 3 glands found by exclusion. We have to make sure that there's no other gland in the neck. Again, the anatomy. Because we are dealing with a recurrent laryngeal nerve, it's not about practice to damage the nerve. So we have to find it. Before doing anything, the superior gland is posterior to the nerve. It's more consistent compared to the inferior one, which could be down in the chest, which is definitely a nightmare. Again, basic histology. What's important here is 50% parenchymal cells, 50% fat. What does it mean? Is it one of the scientific rubbish? Because sometimes you mistaken a gland with a fat globule. Fat doesn't sink, floats on water, but the parathyroid gland sinks. This is another crude way of differentiating between thyroid gland, parathyroid gland and fat. But this is not scientific. You shouldn't rely on this. If you rely on this, you are cutting corners. You'll get lost. This is traditional teaching, primary, secondary, and tertiary. I will not dive in the deep sea of definitions and explanations, because we don't need it. But from the primary point of view, 80% what does it mean? It means 20% could be multiple adenomas, could be hyperplasia. And bearing in mind that 20% could be multiple adenomas, it could be hyperplastic glands, it has an effect on the decision making on how to localize them. Because localization almost always inaccurate in hyperplastic disease and in multi-gland disease, even in the primary setting. Secondary and tertiary. Fine. For surgeons, they will see primary hyperparathyroidism. But nephrologically, we'll see the secondary and tertiary one. So it's important to know what's a primary, how the primary looks like, to compare it with the secondary and tertiary. You will discover that the primary is different disease, different patient, compared to the secondary and tertiary. Even different operation. The primary one is common in women, 50% of them above the age of menopause. Prevalence roughly 3 in 1,000. Standard textbook presentation, asymptomatic, renal manifestations, anatomical, stones, calcification, so on, functional, polyuria, oliguria, anemia, skeletal, pathological fractures, articular, joint pain, neuropsychiatric. Actually, most of the asymptomatic have neuropsychiatric manifestations. So, the asymptomatic category really exists. You know what happens? When you operate on primary hyperparathyroidism, take a history from the patient before the operation. Ask a question, take a history. Do you have any problem? No. Do you feel well? Yes. Body pain? No. Are you okay eating and drinking? No problem. Any abdominal pain? No. Operating health. In the follow-up clinic, let's just say a month after the operation. How do you feel? A lot of patients give me this answer. I feel a lot better. I think I was rubbish before the operation. My colleagues told me that my mood has moved, has changed. I'm more cheerful. I didn't realize how bad I was before the operation. I didn't realize that I was a bit depressed before the operation. So the neuropsychiatric manifestations are quite subtle and usually discovered in retrospect. So don't rely on the asymptomatic category because most likely it doesn't exist. I'm reminding you, I'm talking about the primary hyperparathyroidism, still having moved. This is standard teaching, you know, preostal bone resorption, tuft and radial aspect of phalanges, and this is pathological fracture. Again, it's not a common presentation these days. This is from the history book. Cardiovascular system, hypertension, arrhythmia, gastrointestinal, duodenal ulcer, pancreatitis, abdominal pain, premature death. I think Prof Ahmed discussed it in details. Whether you operate on or no, it will not affect the survival. Still, they will die prematurely. Few distressing pictures. Captain Marshall, before the diagnosis of primary hyperparathyroidism, was well. After primary hyperparathyroidism, again, this picture from the history book. This is a shrinking man, renal failure patient. Before being diagnosed with having renal failure, before having renal failure, after developing secondary hyperparathyroidism. Again, from the history book. This could be one of the presentations, hypercalcemic crisis. Commonly with ectopic PTH, pancreas tumor, or any malignancy, but it happens as well with primary hyperparathyroidism. You have to diagnose and treat at the same time. It could be life-threatening condition. Rehydration and then start calcitonin, and then protonate later on. You may operate as soon as to save them. In primary, it's completely different scenario from the secondary and tertiary. You have to bear in mind the differential diagnosis. Because primary hyperparathyroidism is not a common disease. You have to think of malignancy. Primary or secondary. Again, a disease in the book, but I haven't seen it, to be honest. You know why? Because usually the endocrinologist will see this patient rather than me. They won't refer him to me because he doesn't need surgery. Familia, hypercalcemic hypocalcemia. Hypocalcemic hypocalcemia. It is autosomal dominant heterozygous disease. The homozygous one usually die in infancy with severe neonatal hyperparathyroidism. What happens here? The calcium sensing receptors in the parathyroid gland are set at different levels. So it responds to slightly higher calcium level than normal. pH is normal, and this patient absorbs calcium from the tubules, so calcium excretion is low. So you have a family history, normal pH, low urinary calcium. And to be more accurate and more precise, calcium creatinine clearance will give the clue. Don't forget endocrine disease as well can cause hypercalcemia. There is an exhaustive list. We can carry on till tomorrow. Granulomas, TB, sarcoidosis, drug use. Investigations. The taste book is full of a lot of things. Total calcium, PTH, hyperphosphatemia, 75% of patients, phosphaturia, 50% of patients, hypercalciuria. This is too much. So what you need is total calcium and PTH. Forget about the rest. Do you need ultrasound scan? Need a scan? I put some question marks here. Because you may need it. We'll discuss this later. What about the new operation? Definitely you need localization. For any reason, no question about it. We can argue whether you need it or not for a primary operation. But for a reason, you need it. Otherwise, you can't operate. Basically, you never know where the parathyroid is. Fine. Localization. People fancy these days, having scans, having BB scans for parathyroid disease. But we need to know the sensitivity and specificity of each scan before we request. Otherwise, it will be wasting money, wasting resources, plus the scan could be deceiving. And this is the case in secondary and tertiary. And in 20% of the primaries. Ultrasound scan. Bear in mind, ultrasound scan is operator dependent. You can see the figures here. Between 65 and 85. Between 30 and 90. Wide variation. Because it is operator dependent. In obesity, it's difficult. Multi-node avoidance is difficult. Or inexperienced radiologist. Do you think CT scan is more accurate? No. It's 46 to 87%. But it's required for a regularization, a redo operation. MRI, again, the same like CT. MIB scan is more sensitive and more specific. But again, for single adenoma, but not in multi-gland disease or hyperplastic disease. Do we need localization for secondary and tertiary? The answer is no. Because these scans are not sensitive in multi-gland disease. It will show you two glands, but won't show you the 4 glands. We know in secondary and tertiary, they are there, hyperplastic, even adenomatous. We find them. The scan rarely find the 4. Show you some studies to support the view of no localization is required for secondary and tertiary. Can you see the sensitivity of ultrasound scan in secondary and tertiary? 33%, shocking. Systemic scan in secondary and tertiary, again, shocking. Combined together, again, shocking. As if you're playing with the knives. It will not offer any advantage. For primary, which is the top line, 78%, 80%, so acceptable, both together, yes, but not for secondary and tertiary. Let us see MIB scan alone, meta-analysis. Hyperplasia is 44%. Double adenoma, 30%. So when you request a scan with sensitivity of 30% in renal failure patients to localize the glands, is waste of money. This is immune scan localizing adenoma. Remember, the salivary glands will take up the tracer as well. Fine. Back to the primary. Remember, MEN1, MEN2A. Multi-gland disease, usual hyperplasia, localization is not required. Don't forget ectopic PTH. And this is an X-ray, plain X-ray, of a patient with pancreas tumor. And this is a cause of the hypercalcemia. What about normal calcemic hyperparathyroidism? If you have PTH of, let us say, 1000, and calcium is normal, still hyperparathyroidism. What about normal PTH and high calcium? Is it hyperparathyroidism? PTH is normal.
PTH like peptide from other tumor, cancer or something?
No, actually the kids will measure PTH, will never measure any other things. Because now we're measuring the whole molecule of PTH. It's 84 amino acids of PTH. So if you have normal PTH and high calcium, hyperpara means the calcium is
PTH
high.
like peptide?
If you have ectopic hyperpara, the PTH should be suppressed. PTH is normal. No. This is still primary hyperparathyroidism because the gland is not suppressible. So even normal PTH with high calcium, provided that we excluded other causes of hypercalcemia, is still hyperparathyroidism because the gland is not suppressible. Actually, renal failure is not unusual. When serum calcium is normal, PTH 3000. I put check ionized calcium. Again, from the history book, you don't need it. Check PTH. So, what happened to the gland here? The set point. So the gland went mad and the receptors not responding to the normal calcium level. It has to be higher to respond. So we call it the set point theory. But this is academic. It has no relation. Management. Still in the primary hyperparathyroidism anemia. Asymptomatic. Why not to conserve, rehydrate, mobilize, give HRT, chlorogenic. And actually, the National Institute of Health in 2002 came out with a wonderful guidelines defining when to operate on primary hyperparathyroidism asymptomatic patients. Anyone develop clinical manifestation of hypercalcemia? Calcium level 1 milligram above the reference range. Urinary calcium excretion more than 400 milligram per day. Calcium clearance reduced by 30%. Bone density score minus 2.5 at any site. Younger patient, about age of 50. This is rubbish. Because nothing called asymptomatic hyperparathyroidism. They have neuropsychiatric manifestation and usually discovered retrospectively after the operation. Because the patient compares between his condition after the operation and how he was before. Now, parathyroidectomy for primary hyperparathyroidism. This patient is different from the renal patient. But same principle applies. If you are planning to do bilateral liquid separation, and this is the standard operation, you don't need authorization. But if you requested localization, be prepared mentally that something is not on the scan and you find it in the patient. Another way, don't rely on the scan. Keep it in your mind. Let's tell you, if the scan tells you that you have superior left, yes, it must be superior left, but don't forget the inferior left and the right side as well. If you are planning to do minimally invasive, this is the place for localization or unilateral parathyroidectomy. You know, like gallbladder, when we started laparoscopic cholecystectomy how many years ago, people were interested, people were resistant to change. When we started laparoscopic fundoplication as well, people were resistant to change. When we started laparoscopic hernia repair, people were resistant to change. This is a fact of life. We don't like changes. But, in my opinion, we don't need the local minimally invasive one because the incision is small anyway. But pioneers in parathyroidectomies, especially the minimally invasive one, set some regulations. You don't need to do minimally invasive for reoperation because everything is hard, everything is a nightmare. Negative scans, MBN and multi-gland disease. So there is no place in the renal failure patient. Forget it in the renal failure patient. Irritated neck, multinodular aorta as well. You find lesions everywhere. Secondary, I'm a surgeon. I don't like to talk too much, but I love to use a knife. Mechanism, I think Prof Ahmed and Prof Hussein discussed it in detail. Most importantly is vitamin D deficiency, inability to activate the vitamin D. Pruritus, soft tissue calcification, bone disease. The commonest presentation is back pain, not status fibrosis cystica. Could be presented as well with calcifilaxis. It's common. You will find it in renal failure patients and transplant patients, and being reported as well in primary hyperparathyroidism. You have high PTH, high calcium. You have tender cough. You think it's inflammation, it's cellulitis. You start taking antibiotic, but it will slough off. Fingers will slough off. The toes will slough off. You have gangrene. You need urgent parathyroidectomy. And this is distressing pictures of calciphylaxis. We started with light cellulitis, being treated with antibiotic, not responding to antibiotics, start to slough off. This is another picture of calciphylaxis, patchy distribution. It could look like burn. Right. With isco like burn, as if the patient had burn. Penis is gangrenous. So this could be one of the presentations of calciphylaxis. Usually 2 minutes. Investigation. Again, PTH and calcium. But the PTH in renal failure patient, as Prof Ahmed said, is different from the reference range we have for non-renal failure patients. We consider to check 5 times the reference range. To be honest, I don't operate on renal failure patient unless PTH is above 1,000. Hypophosphatemia. Again, lower radiological investigations are required for obvious reasons. Treatment. I don't treat them. Prof Mujib, Prof Hussein will treat them. And failed medical treatment is for me to do something. So the nephrologist will treat hyperparathyroidism, secondary hyperparathyroidism. Fine. What are the chances of renal failure patient to develop secondary hyperparathyroidism? 100%. By definition, kidney is gone. Vitamin D is not activated. Not treated, 100% chance of developing hyperparathyroidism. Only 5 to 10% of them will land in surgery. The operation of choice, because we'll discuss it later. We remove 3.5 glands. And I put million lines under thymectomy as well. Remember, the first slide we discussed the anatomy, we mentioned could be 5 or more. Where to find them? The thymus. The thymus usually has some parathyroid cells get activated in renal failure patients and could develop adenomas later on. So part of the package is thymectomy as well. 3.5 glands, yes. Why not 4? To avoid aerodynamic bone disease. But again, million lines under but. You need to have histopathologists next to you to confirm that the gland you're leaving is parathyroid tissues. Semicalcite. I went out of business actually a few months because of semicalcite. Because it definitely an effective drug. But is it cost effective? The answer is no. Both rate is cheaper. And now في القرص 30 ملي جرام ب 50 جنيه باين ولا 60 جنيه مصري مش كده؟ مين يقدر يدفع الكلام ده؟ طيب ده 30 ملي جرام طب لو قعدت ازوده 60 120 it's too much. Cheaper. Nice guidelines recommend that semicalcite for unfit patients or patient refuse surgery. Cost implication, you have to keep it in your mind all the time. Tertiary. We're not now even in the deep sea of definitions because it has many definitions. I'm not interested in this page. But from the transplant point of view, kidney transplanted, correction of the calcium abnormalities, but the gland is still hyperactive. Usually, we'll wait for a year. The gland may be hyperplastic or any stage of hyperplasia, might go back to normal. And it happens. It succeeds. 30% of patients have tertiary hyperparathyroidism after transplantation. Only 5% require surgery. So we will succeed in a vast majority of these patients. But another variation here. During the operation of transplantation, you will find 1 or 2 glands only. Is it partial resolution of secondary hyperparathyroidism? 2 glands improved, the other 2 didn't. Or is it a sporadic hyperparathyroidism, primary hyperparathyroidism? Could be. I've seen it. And even during the operation, on a renal failure patient who developed what you think is Second, hyperparathyroidism from only one gland. It could be primary hyperparathyroidism in renal failure. But, again, this is by seclusion. You clean the neck, you just sit the neck fresh and cool. It's difficult operation. Didn't find any. The only place which you can't look is the chest. We'll discuss it later. The treatment is different here. Treatment is surgical. For good reasons. After a year, no improvement to operate. Because phosphate binders will work. Because they are hyperphosphatemic. If you remember in transplantation, you give calcium inhibitor, and calcium inhibitor causes hypophosphatemia. Calcium is normal or high, so you can't give calcium. They are refractory to vitamin D, but we still give it. But lucky enough, most of them will improve within a year. This is how we do it. Small incision in the neck. This is typical thyroid gland of renal failure patient, full of veins. Renal failure patient's neck is the worst neck you will ever see. Lots of veins, arteries calcified, big bleed, difficult to stop bleeding, healing power is rubbish, scrap. And the patient is half dead before you start. Hopefully you won't complete the circle. Mobilizing the gland is all about mobilization and exposure. If you do the step very well, you will enjoy the operation. If you cut corners, you'll be in a big mess. Prefrontal fascia means you mobilize the gland nicely. Even if you stick your little finger into the base of the skull, means the gland is well mobilized. So on one side. This is right superior part. Then, look for the nerve. Remember, we don't like this patient ends up by tracheostomy. So look for the nerve, look to damage it. Once you find the nerve, place it in the glands. I found something here, I wasn't sure about it. I sent it for histology. Came back as parathyroid gland. Because even if you're 100% sure, still you can miss a gland. So you need a histopathologist to do a good job. Unfortunately, we don't have an Egypt here, a histopathologist who can do frozen section on the spot and give you accurate diagnosis. Left superior para. I found only 3 glands. What do we do next? Only 3 glands. I clean the neck right and left, up and down. I open the carotid cheese, the center of the carotid artery, internal jugular vein. I went messing around in the superior intestine with my finger. Base of the skull. Nothing. Must be in the chest. There's no other place. Poor comments opening the chest. Small incision. Median stenotomy. Who agrees? Who says no? No. No? Yes.
No.
If you said yes, my friend will laugh at you. Yes, you're right. You shouldn't do it now. You need to localize it. I'm trying to make it easy for you, but it's not. It could be down to the aortic arch.
So, my question, why to avoid scintigraphy?
Fine. 6 months later, patient had hyperparathyroidism, pH about 1,500. What I need to do. After removing 3 glands. Here, you need to localize it. You need to know where it is. Opening the chest in a renal failure patient is not straightforward operation. He got cracky bones, healing power of the sternum is poor. We end up with osteomyelitis. You need a cardiothoracic surgeon who knows how to open and close the chest for this half-dead patient. Very sick patient to deal with. You don't need to take any chances. You have to maximize your success by good preparation. Thank you.
My question, sir, first I would like to thank you about this interesting presentation. But my question about why to not to use scintigraphy to localize in secondary or tertiary?
Because there are no sensors. If you look at the slide, 30–40% sensitivity, and we show 1 gram, 2 grams, but not 4 grams.
But in the situation you mentioned, you lost 1 gland. Why to localize 4?
I mean, sensitivity, basically, you know, the glands are there, but not picked up by the scan. So it's useless. Identifying 1 gland is not an answer. Still, we have 3 missing.
Hello. Please, we want to know about Sheffield pre-operative and post-operative preparation protocols doing calcium level, calcium supplementation, and calcium level measuring post and pre-dialysis. So, what's your experience?
Fine. Basically, actually, you check calcium every 6 hours and you get calcium infusion. And before the operation, we load them with alpha-calcium. 2 micrograms to 3 micrograms daily. We try to avoid the hypercalcemia post-operative, but still we get it. And when we get it, we treat it with IV calcium. And then we the patient with IV calcium, give him oral calcium.
So, we release our investigation. We have to look at.
No, but it's important to know the patient with alpha-calcium pre-operative, 100 pre-operative, to avoid post-operative hypercalcemia.
Exploring localization with this high-risk patient and the chance of repeat surgery is difficult for this patient. Why do we find the staff to localize, especially intrathoracid localization and malignancy? The second thing, what's the benefits like potential abuse? Why is this gland in a reduced surgery or in a trials in the way trying to do this benefits?
Thank you, Dr. Man. Actually, embolization never tried. You know, if you do selective venous catheterization to check the PTH, it will tell you lateralization rather than localization. And the big difference between lateralization and localization. Lateralization will tell you which side the gland is, but it will tell you where the gland is. Here, down there. It will tell you the gland coming from its gland on the right side or left side. It's a very tiny blood supply. You can't detect it. Even sometimes there is no artery to tie, just the areas. When you compress them and they stop. It worked a different lesson. And what was the first question?
Why do we do localization?
If you do a scan, if you do ultrasound scan will work because the ball is in front of the, you know, you are scanning the ultrasound scan, you are scanning the room because the sternum in the way. Maybe scan, sensitivity is low, and you not pick up. I would say 70% chances of not picking up the ectopic pathway. will be left with one gland only. You're both free, most likely there's only one left. Sensitivity is higher if you have one gland. The sensitivity is higher in single gland disease.
Area of technician subtraction is it used now or
Still used. Maybe scan, yeah, absolutely. It's still will be used and sensitivity is high in primary and single gland disease in regional.
Pesticide for reimplantation of the gland in case of total parathyroidectomy. Because I think in case of the parents post parathyroidectomy, you have to look at blood pressure, I think, to retake and to measure the VDH. What is the value of this test?
What you need is healthy muscle, whether in the arm, leg. I don't hit the neck. Because when you open the neck, sternal muscle is exposed. We make few pouches. I mince, smash the glands. A tiny bit of the gland equivalent to 50 milligram, and put it like slush and put it inside.
how can we differentiate? Is it became hyperfunction or another size?
Fine. It depends on the finding. Good first operation will save your back. You found 3 or 4 glands. Let's say 4 glands, right? Remove them. You remove the thymus. Nothing left behind. You transplant it or implant a tiny bit. If recurrence happens, most likely from this time you transplant it. Easy. But if you are not sure about what you have done, shortly within a month of the operation, you can PTHS return.
I want to ask you a question regarding your rate of operation. What is your failure rate? Because I am annoyed by the 50% failure in my center. What's your failure rate in the
My failure rate, I can't remember how many I did so far, but a lot. And I have 3 patients fail. But failed because the glands in the chest. 2 of them, we couldn't operate on them. So they refused surgery, giving stomach cancer.
So you mean
the other one is very poor, in poor health, we can't operate it anymore.
So your answer is the secret in the center is operated within.
Yes. I mean, if you're looking at if you're talking about gland in the chest is more than 2% of your chest. So if you cure 98% and you left at least 2%, which is difficult to cure because down in the chest, is a good success.
Yes.
No one will get 100% success. 50% is poor. Maybe everything is ignored. The intrathyroidal gland as well. I think 1 to 2% intrathyroid. In case of if I found 3 and I couldn't find the 4th one, I would slice the thyroid gland, usually the lower one, and make cuts. Sharaha. It bleeds a bit on section. Bleeding doesn't worry me. As a surgeon, I don't mind. When I'm missing a gland, I don't mind. I have done it once. Yeah, I've done it once. I found a gland, and the gland ruptured inside the thyroid gland. So I had to take the release. Remember, contamination of the feed with a parathyroid cells is a disaster, and it's called parathyroidism. Like malignancy, seeding of parathyroid cells all over the place. Recurrence is guaranteed. Treatment, no, can't do it. So I'm taking the rule to make sure the field is clean without having any parathyroid cells seeding the work. One side, yes. Usually on the side, you can go. If you are not sure, if you think that you look carefully all around, and you couldn't find the fourth one, you can do a chemotherapy. And that's fine. But remember, this neck cannot be this again. I mean, you can visit the neck for thyroid surgery. Redo, no problem. Yes, but the way to do the parathyroid, you stick the recurrent laryngeal and the lower range. You move around the trachea. If you feel it down, you go to the other side. So there is no chance for you to come back. Injury is guaranteed.
Thank you very much, Dr.